Oh, this is great. I just stand here and everybody gets quiet. I don't have to say anything else. I'm impressed. Well, first of all, welcome. I am Stephanie Fidel, and I have the privilege of serving as the president of our MAP Community Services Board of Directors. As many of you know, MAP Community Services is a statewide organization dedicated to empowering people with disabilities to live their best lives. Ivy Street, which is one of our 3 divisions, has a special education residential and day high school for neurodivergent youth. We work with students to prepare them for adulthood with the tools they need to achieve their greatest independence. The Ivy Street's Pratt Lecture series, which is why we are all here, strives to help students' outcomes. We have 2 other divisions, the Massachusetts Association for the Blind and Visually Impaired, which provides vision rehabilitation and support services throughout Massachusetts to more than 1,200 adults, primarily older adults who are blind or visually impaired. And our 3rd division is our Adult Disability Services, which provides residential supports, community living supports, transitional assistance, occupational therapy, and vocational services for individuals with developmental disabilities, brain injuries, and other disabilities. And these homes are throughout Greater Boston, Southeast Boston, and Central Massachusetts. So, before we get to our actual program, a few housekeeping details. First, thank you to WBUR and CitySpace, and also to those of you who are not in the room but on Zoom for being with us this evening. This program is being recorded. Here at CitySpace, behind me, I guess over there, in the back of the theater, left-hand side, left-hand side, okay, that way, right and left, there's a door leading to 2 accessible restrooms. Doors leading to the lobby are on the right-hand side of the room. And if you need assistance during or after the program, please raise your hand, as we have volunteers from Delta Gamma or a MAB staff member will help you. Now I'm delighted to recognize the following guests who have joined us this evening, beginning with James and Betsy Pratt, Carter Pratt, and Chris Sassetti, and all of the generous donors to the Pratt Lecture Series. Thank you so much. To our speaker, Dr. Insel, sitting here in the front of the room, we're all really excited about your presentation, and thank you. To my fellow board members who are here with me tonight, to the executive leadership team and staff, to the Ivy Street families, students, and alumni, and of course, MAB's immediate past CEO, Barbara Salisbury, and her husband, Luke. So it's now my pleasure to introduce MAB Community Services CEO, Michael Panicola, who joined MAB as our CEO this past January. And let me begin this introduction by saying how delighted we are that he accepted our offer to come. And a bit about Mike. He grew up in Chicago. He holds a PhD in healthcare ethics, was a faculty member at St. Louis University, or SLU to those who know and love it, for many years, and for 2 decades was a senior executive at SSM Health, a nonprofit healthcare provider with facilities in 4 states. Prior to joining MAB, he served for 4 years as the CEO of Epworth Family Services. So please joining me in welcoming Mike Panicola.
Can I move this? Yeah. Well, thank you, everyone. Thank you, Stephanie, first of all. Thank you to our board members, Dr. Insel, Barbara, of course, and all my colleagues who are here. It's so fun to be here for my first kind of big event. As I've told several people already, speaking is not my favorite thing to do, so I won't make this long. But I know I've been asked to say a few words about me and sort of what brought me to MAB. And I think just one thing to know about me without going into, and I can't get this to stay, so. One thing to know about me without getting into great detail is, because of some experiences that I had and limitations, there weren't many people when I was younger who thought I'd be up here working with all of you. And I had a high school so-called guidance counselor say, yeah, everyone else is going to be applying to colleges. Maybe you should think about, something else. And who didn't know anything about me or, what a young kid's experiencing at that particular time in his life or her life. And but I had a few people who have been so instrumental to help me see in me more than what I ever saw in myself. And I was fortunate, Stephanie mentioned that I worked in healthcare. And I know a lot of people work in healthcare. I really feel that's where something matched with what I was feeling inside. And I worked it was a Catholic system. And but the great part about it was run by nuns, so don't have all the associations with what you typically may with Catholicism. The nuns they called them the Sisters of St. Mary because they came from Germany in the 1800s and stayed at this church called St. Mary's right on the Mississippi River. And they were truly pioneers. They were, what we would call today nurses, but they were going out, in battlefields. They were going to epidemics, addressing, caring for people with smallpox, risking their own lives and in many cases dying. They were leaders in the civil rights movement. One of our sisters, Sister Ebo, walked with Dr. King in Selma. They started up a hospital where Black individuals, Black healthcare professionals could actually practice without being in a real segregated environment. And what I learned from them, and particularly this woman named Sister Rose, was, I think, two things. One is, we're called to address the great need in the world. What that is and how you evolve to meet that may change over the time, but that calling to meet the need is one thing. And the other thing is ultimately what we're doing is we're not, I think learning from the so-called missionaries who tried to convert and do all these things, we're not going in and transforming. They're teaching us as much as we're there to provide supports. We're there to empower as much as we can. And ultimately we're empowering so that they can live their fullest, best lives. She used to say flourishing all the time, however you define that. So anyway, why did I come to MAB? I left healthcare because frankly, healthcare got too businessy. And I think the heart was kind of stripped out of that sisters organization that was founded in 1872. And Sister Rose herself said, you need to go somewhere else. Like, you're getting too angry, here. You're challenging people the right way, but, it's time. And 19 years, it was time. So I moved into social services, and ultimately I got here to MAB. And it's one of those things, I was talking to Darlene, who's taking the beautiful photographs you'll often see around MAB and will be shared tonight. But sometimes things just come together. And I can't say it was choice or fate or luck or maybe all those things combined, but it feels right. Being with the team and the colleagues, it doesn't feel like I wasn't ever here, if that makes sense. And I don't mean that in a bad way. We did jump right in, but no, but it just feels right. And I think what made me really feel good was early on we were at Ivy and doing a very intentional handoff with Barbara saying goodbye and the students saying hello to me. And one of our students kind of came out of her way after I had said a few words and was leaving, and I said I was nervous, And she came to find me and she grabbed me and she said, I get nervous too, when I have to talk out there. She said, you're gonna be great. And so that was enough of the confidence I needed, and I'm happy to be here. And now I have to, I'm delighted to introduce my colleague, Brooke Howard. Brooke, I've only known Brooke, 2.5 months, but again, she's one who I feel very comfortable with. I can honestly say Brooke runs our Ivy Street school and programs. And as a parent, there is probably no one who I've ever met who I'd trust more to be overseeing my kids' lives and development than Brooke. She really is a tremendous person, tremendous leader. Happy to be her colleague. I learn a lot from her. But to give you some details, Brooke has a master's degree in occupational therapy from Sargent College at Boston University and an undergraduate degree in neuroscience from Oberlin College. She's worked as a licensed occupational therapist since 2005. And before coming to Ivy Street in 2009, she worked in inpatient and outpatient rehabilitation and supervised the outpatient program at Franciscan Hospital for Children. From 2010 to 2014, Brooke also was adjunct faculty at Sargent College, Occupational Therapy Department. And she was a founding member of the transition program at Ivy Street and also co-founded Ivy Street's community-based program called Skills for Life, where she worked with young adults seeking to gain more independence. So without any more, please join me in welcoming Brooke.
Thank you, Mike. Welcome. The Pratt Lecture is one of my favorite nights of the year because we have the chance to all come together as a community. And I always see familiar faces across lots of areas of work, both academic work, our community partners, our stakeholders, families, students, and always plenty of staff here as well. We're all here for different reasons, and we all come with a different perspective, but I wanted to start out our program by giving you a chance to hear from the people who really drive me every day, which is our students. So we're gonna take a minute to watch a short video so we can hear from some of our students and what their life is like at Ivy Street.
What made me choose the Ivy Street School is because of jobs and opportunities of learning more.
I really liked the environment of the school. Like, it was in a quiet neighborhood but near a busy city, lots to do. I also liked the photography and culinary options, something I like to do.
Well, I wanted to come here because I got a good vibe off this place.
It's a good place to be, and you get to hang out there.
I wound up coming to Ivy Street because my mom helped found the program. Honestly, in part or in whole for me, or for all the post-high school graduates that don't quite have the life skills or executive functioning to function in a college setting yet.
The goals I wanted to make progress on were decreasing my anxiety but increasing my communication.
The goals that I want to make progress on is to keep myself together, not disorganized or angry.
I wanted to work on my social skills a bit, round that out, things like that.
Making it through the day.
My goals upon coming to Ivy Street were to further my education, get better life skills, learn how to live with myself, and possibly with other people.
I used to be really shy around people, but now I've gotten more comfortable with them. I used to hate living away from home, but now I'm exploring the Ivy Street apartment to practice more independent living.
I think I changed more as a person who cares more.
Got a bit more social, and less withdrawn, more outgoing, and contrary to all popular belief and all-known laws of physics, I've actually gotten that much more awesome.
Going out in the community and having lunch.
I'm a lot more patient, and a lot more able to finish things.
Things I'm still working on are my communication skills, banking, and finding a job.
I'm still working on things that are more memories and trying to overcome the stress that I already have.
Still a bit of a hair trigger response to annoyances, trying to tone that down, But I've rounded a lot of stuff out.
I still have to work on taking care of myself.
2 or 3 highlights from Ivy Street. Probably meeting some awesome people, making friends, and performing in the talent show.
Gotta say, I am really proud that I aced my psychology course last year. I mean, that's big.
We held a food drive and liked it, and it was nice. We gave back, and it was super successful. That's what it'll do to me.
All right. So I think I've heard a few people say already tonight that, our approach is really to situate the voices of our students, the voices of our families, their goals and their challenges at the forefront of our work. And we feel really strongly that it's important always to remind ourselves that we are here in their interest, not necessarily in ours. So now that we know who's at the heart of our work, I will share a little bit about the Ivy Street School. Ivy Street offers programs that provide neurodivergent youth skills to thrive. We focus our programs around the goals of the individuals that we serve. So we have the Ivy Street School, which is a high school and post-secondary program for day and residential students. And that program includes therapeutic support, career development, the development of self-determination skills, and also interdependent living skills. We have our Skills for Life program, which is our community-based occupational therapy program. And through that program, we support individuals to identify their strengths, their priorities, deepen their self-awareness, and to build skills, again, that allow them to realize their own goals. And then we have our Community for Life program, which includes our Turning 22 residents, which we partner with MAB's Adult Disability Services Division to run. And we have an alumni mentor program as well. I also wanted to acknowledge that we're here tonight thanks to the Suzanne John Pratt Lecture series, which has allowed us to bring speakers to our community whose work can inform and impact our practice. It's an opportunity to bring people who have varied experiences and who have something to share with us that can help us improve to really meet the goals that we want to meet. Over the years, the Pratt Lecture speakers have helped us to better serve our students, families, alumni, and community. Tonight, we welcome Dr. Insel to help us understand the system in which we work, what works, what doesn't, and how we can make and advocate for changes that will impact our goals and the experiences of our students. I think we all can recognize it's been an especially challenging moment in the mental health care field, in the field of education, and so we're really grateful for this opportunity. Tomorrow, Dr. Insel will visit the Ivy Street School, and our students, staff, and families will also have an opportunity to speak with him, to share their experiences, and to get his thoughts and insights. I wanted to thank the Pratt family and all of the generous Pratt donors for helping us to create and sustain the Pratt Lecture series. Special thanks to James and Betsy Pratt, and to Carter Pratt and Chris Sassetti for joining us tonight and for their leadership and generosity. We hope that the difference you continue to make and how you continue to honor your father's legacy and your mother's leadership brings you great joy. The Pratt family's patriarch, John Pratt, served as the associate director of the Whitehead Institute for 25 years, and he was also a member of the MAB Community Services Board of Directors. John cared deeply about the work that MAB and Ivy Street do to help young people with disabilities develop the skills they need to build successful lives as adults. A former social worker, mother of 2, grandmother of 4, and loving wife of John, Suzanne Pratt also played a significant role in launching and sustaining this series. Thank you for providing us with this exceptional opportunity. We've had many in the past, and are always grateful for the chance that we get for these lectures, so thank you. And now I have the true pleasure of introducing Ethan Slaybaugh, who's our Ivy Street's Director of Nursing Quality, and he will be introducing Dr. Insel. While pursuing his bachelor's degree at the University of Michigan School of Nursing, Ethan worked as a psychiatric nursing assistant at C.S. Mott Children's Hospital while also working as a certified personal trainer specializing in medically complex clients. After graduation, Ethan worked as a registered nurse in a local underserved community in southeastern Michigan with Ascension Hospital. He quickly realized he wanted to do more for this underrepresented population and started his pursuit towards graduate school. He went on to continue his education at the University of Michigan once again, this time to receive his doctorate degree while working as a registered nurse with Michigan Medicine. It is my pleasure to introduce Ethan. Ethan is truly a rising star. He is a deeply committed clinician, a talented and compassionate leader, and an incredible advocate for our students. We're very lucky to have him, and I'm excited to introduce you.
Thank you, Brooke, for that beautiful introduction. Hello, everybody. Hi. And hello, Dr. Insel. Thank you for joining us here in Boston to share your wisdom, to challenge our thinking and practice, and to listen to those of us that may have questions, comments, and maybe some complaints about our current mental health system. Before I introduce Dr. Insel, I'd like to briefly reflect on his book, Healing: Our Path from Mental Illness to Mental Health. Ivy Street generously provided his book to the members of our leadership team at Ivy. At first, I thought this was with no strings attached. And then I found out we were assigned homework and we're to openly reflect with one another on how this book pertains to our own work and what we gain from reading it. I don't know how I was able to find the time to read a book, nonfiction at that, with all the other priorities in life and work. But that question's irrelevant. My hands were tied and I needed to find the time. Even as someone who is not a big reader, I found reading this introspective and engaging. The book changed my perspectives, my emotions, and the outcomes I foresee in my own future in mental health care advocacy. Reading this book led me to think about what I and the rest of Ivy might do differently. What might a better path to mental health look like? How can we better support people with serious mental illness and successfully transitioning to the next stage of our lives? Hopefully, without stealing too much of Dr. Insel's thunder, I'll briefly mention one of my key takeaways from this wonderful read and how we can help support. And that is the 3 Ps: people, place, purpose. By addressing and reframing how we view mental health recovery, these 3 simple but powerful elements can truly help reshape this current idea of the reactive psychiatric care and management and can lead to such better outcomes. People, the importance of social connection and support systems. The idea that we, as humans, need strong relationships and communities to thrive. Place, the importance of a safe and supportive environment. The idea of having access to resources and stability. And purpose, the importance of finding meaning and purpose in life. The idea of creating motivation and overcoming challenges. After reading Dr. Insel's book, I see a vision in which mental health is prioritized, stigma is reduced, and so many of ourselves, our loved ones, and others are able to live full, meaningful, connected lives. Okay, enough about my perceptions on the book. Let me tell you about the reason you're here at Ivy Street's 2025 Pratt Lecture, Dr. Thomas Insel. Dr. Insel is a psychiatrist and neuroscientist who has been a national leader in mental health research, policy, and technology. From 2002 to 2015, Dr. Insel served as the director of the National Institute of Mental Health. More recently, from 2015 to 2017, he led the mental health team at Verily, formerly Google Life Sciences. In 2017, he co-founded MindStrong Health, which builds tools for people with serious mental illness. And since May 2019, Dr. Insel has been a special advisor to California Governor Gavin Newsom and chair of the board of the Steinberg Institute in Sacramento. Dr. Insel is the author of Healing, Our Path from Mental Illness to Mental Health, published by Penguin Random House. With journalist co-founders, Dr. Insel recently launched mindsightnews.org, a nonprofit digital publication focused on mental health issues. Dr. Insel is a member of the National Academy of Medicine and has received numerous national and international awards, including honorary degrees in the US and Europe. Please join me in giving a warm welcome to Dr. Thomas Insel. Thanks.
Wow. Thank you, Ethan. That was wonderful. And what a great set of comments. I love the video, by the way, Brooke. That was terrific. I'm really honored to be here, and I want to start by thanking the Pratt family and the other donors for supporting this opportunity. So excited to meet with a bunch of you tomorrow, see the school, get to know more about what you're doing. I actually do these events mostly so I can listen more than speak, and I can learn more than teach. I don't have that much to say, but what I thought I'd do, I mean, if I'm brutally honest, this is a very weird moment in time. And there's some really exciting things to talk. It's like the best of times and the worst of times. I mean, it's like there's real opportunity right now. And I'll talk a little bit about the excitement of what we can do. And then there's all this stuff. You probably saw that there's a new executive order to basically close the shutter of the Department of Education today. We're going to have to talk about that. So what I think I'll do is go through my slide deck, which I often do for these things, but I really want to leave some time to sort of think with you about what are we going to do about this? What does this mean for the school? What does it mean for our students? What does it mean for our families? What does it mean for all of us? And I actually don't know. I don't have the answers, but we got to talk about this. So let's do that. I'll start by saying that even before any of this, before January 2025, the world of mental health was not doing great. I think we had a sense from our former Surgeon General and even our former president that there was a national crisis, and for 15 million people with SMI and, the tens of millions of kids who are struggling right now. We've got to go a little deeper into what each of these circles look like. For the youth mental health it's odd. It's not like one we've seen before because it's much more internalizing than externalizing issues. It's more in girls and boys. There's a higher acuity because kids, teenagers have always struggled, but this is something substantially different. 52% increase in suicide since 2000, and about 100% increase in self-harming events that end up in the emergency room. So that's a lot. It's a really big increase in prevalence, and it's not randomly distributed. As I mentioned, it's girls more than boys. Kids who identify as LGBTQ are at a much, much higher risk. Just extraordinary. I was looking at some data from Crisis Text Line, which is a texting service where a lot of kids go when they're in crisis. It's like over 50% of the kids who required an intervention, which is actually a small fraction of the 900,000 kids who text every year, but over 50% of them were kids who I self-identified as LGBT or Q, and that's really extraordinary to me. So that's a huge flag we've got to look at. SMI, serious mental illness, is very different. Actually, that's probably not a big increase in prevalence. There's an increase in acuity, I think. But here, I think the numbers for schizophrenia, bipolar disorder, severe depression, severe PTSD, severe eating disorders, they're probably not that much different than they were in 2000 or 1980 or even 1925. I think the numbers are probably fairly stable. What's really changed is us. It's that the care system has failed. And so we see these terrible outcomes. As it says here, there's like a 20-year early mortality data that just is stunning, that people with serious mental illness are dying in their 50s and 60s, the way that people without serious mental illness died in 1905 and 1910. That was the life expectancy then. So more than a century of medical progress totally lost on this population. And they're not dying from suicide. They're not dying from the mental illness. They're dying from common medical problems. They're just not getting good medical care. Cardiovascular, pulmonary diabetes, that kind of thing. Much, much higher rate of incarceration. We'll talk a little bit more about that. And of course, homelessness being a national problem, they're highly overrepresented in homeless populations. And finally, substance use disorder, SUD. And that's actually driven mostly by fentanyl, which has this very, very high lethality. But I put it up here because the numbers are just so stunning. And our kids they're not vaccinated against this. They're not immune to ending up as an overdose victim. We used to talk about recreational drug use, but that doesn't happen anymore. Your first time trying a street drug could be laced with fentanyl, and fentanyl is so powerfully lethal that we have now over 100, this year it's down a little bit, but in 2023, there were over 100,000 deaths from drug overdoses. That number is just stunning. That's about 20-fold higher than the number at the beginning of the century. So this is huge increase in prevalence, especially in terms of mortality. So I want to just stick with this idea for a moment, talking about public health statistics and mental illness, because there's a tendency when we talk about mental illness to sort of assume that it's mild to moderate, and it's not all that serious, and to forget how deadly these disorders can be. Today, we tend to group together suicides and drug overdoses and even alcohol-related deaths as deaths of despair, because often we don't know. It's very hard to tell with an overdose whether it was an accident or was it intentional. And when you look at those numbers, they're just, again, really, really striking, and you realize that a huge increase in lives lost. And here we're mostly talking about people under the age of 30, which is like we're losing a generation here. We're pushing 300,000 deaths in 2023. The good news is those drug overdose deaths have come down. We're not sure entirely why, but they're now below 100,000 in 2024 from provisional data. The suicide numbers are still high. The alcohol-related deaths numbers are probably about that high as well. And I have an asterisk there because it's a little hard to compare 2023 for alcohol because the CDC, from whence these data came, they have started including auto accidents and alcohol-related injuries, which they should, in terms of mortality. In previous years, they were just looking at hepatitis and liver-related mortality. So I want to just take those three bubbles, the youth, the SMI, and SUD, and unpack them a little bit. For youth, beyond the mortality data, what we're seeing is just very, very high prevalence of the kids, as it says, are not okay. And it's this kind of internalizing stuff. It's, anxiety, depression. As I mentioned, you can see these are, again, CDC data from a youth survey that's done every 2 years, where they go to something like 172 schools, several thousand kids, and they simply collect the data on how are you doing on a bunch of behaviors and risk behaviors especially. And you can see that indeed girls more than boys have this persistent feeling of sadness. It's across ethnic groups, although somewhat worse in some groups. And again, as I mentioned before, very high rate, 65% in kids who identify as LGBTQ+. So that's really stunning. To give you a sense of just like the magnitude of this, I often want to put this kind of in context for like the pandemic, where we lost over 1 million people to the pandemic. But what we tend to forget is that the vast majority of those people were over 50. And if you look at young people during the pandemic, there were deaths, about 8,600 for people under the age of 30. But in that same period of time, those 3 years, 2020 to 2023, if you just count up the deaths of despair, suicide, overdose, and we could leave alcohol off, you can see the numbers are stunning. I mean, it is, what is that, 180,000. That's like 15 times higher than the number of deaths from COVID. So the impact of the pandemic, which is continuing, I think, for this generation, was not so much the infectious disease, it was everything else that went with it. And it looks very different than the story we tell about the pandemic now, 5 years later, because this has this very long tail. So the kids are still affected by something that many of us are sort of leaving behind. So that's the youth mental health story. There are other drivers. Social media, obviously, is something we should talk about. There's a sense of something called grind culture, this sense of tremendous expectations, the difficulty in as they look out into the future. I won't be able to do as well as my parents. I certainly won't do as well as my grandparents, and concerns that many of us didn't experience growing up. Lots of things feed into this, and we don't know all the drivers, but it's worth starting to put all that into context so we can understand why this prevalence, why the internalizing impact, why girls are more than boys, much that we still need to unpack. Let's go into the second bubble really quickly, serious mental illness. And for that one, I think we just have to rethink the problem in a way, because we tend to put this within a healthcare context, and healthcare is part of it, but it's a small part. We've got all these other issues that if we want to really take this on and figure out how to solve this particular crisis, we've got to talk about criminal justice, the incarceration of people with a brain disorder, problems with housing, problems with education, all of these things that contribute in a way that we don't usually think about for like a typical medical problem like diabetes or heart disease. This is just far more complicated. And we are not going to make progress until we take on that entire array of issues. This is interesting, and as it says at the bottom here, that actually there's a lot of talk these days about the cost of serious mental illness, but the key to remember is actually the cost is not from treatment, it's actually from lack of treatment. And that's what's driving the problems with whether it's criminal justice, housing, or education. There's all of these things that we are not really thinking about because we haven't begun to even provide basic care. Substance use disorder, again, this is one where so much of the problem, these are New York Times data, and I put this in here just so you get a picture of the role of fentanyl, and just like for context, because I think it's hard sometimes for us to actually grapple with what these numbers mean. But when we're talking about 107,000 people dying from overdoses in 2022, almost 74,000 just from fentanyl alone. Look at the far right, if you can see it. It says total American deaths in Vietnam, Iraq, and Afghanistan wars was about 68,000. So in 1 year, we lost more people to fentanyl, young people, than all the people who died in all the wars since World War II. Peak car crash deaths were 1972, peak gun deaths 2021. So these are just extraordinary numbers. And an epidemic that we haven't quite gotten our hands around, although, as I said, the numbers are beginning to come down. So that's, I wanted to give you some sense of what this problem looks like, these three crises there. It's important to know that any given individual could sit in all three buckets, and across them there are just some common elements where, we have the crowding in emergency rooms that everybody hears about called ER boarding, the problems with crisis care today. It used to be 911, now it's 988 is the number to call, but these are just overwhelming needs for urgent services. The costs are up and the outcomes continue to be pretty dire. So unfortunately, that's the story across all three of these areas. Now, the question I want us to think about a little bit is how did this happen? Why do we have this? And I think if we're going to fix it, we've got to truly understand not only the taxonomy, which I've got here, but what the major sources are. It's really, as it says here in many ways, especially for SMI, this is a care crisis, right? It's like we've just failed to provide the things we know how to provide. When I got asked by Governor Newsom in 2019 to go deep into this area and to try to become his eyes and ears for a while, to try to understand why we were having such issues in California, I spent a year just traveling around the state and talking to everybody I could talk to. And I have to say, I began the year thinking I really understood the problem and understood where the drivers were. And, I'd heard a lot about, stigma and access and workforce. And that was a little bit of what I heard about as I started engaging with families and patients and providers and payers and going to jails and prisons and homeless shelters and all of that. But as the year went on, I began to realize this is actually pretty complicated. There's a lot going on here. And it ended up that there were sort of 5 things that I thought were really going to be the keys to understanding the root of this. The first was that we just didn't have the capacity that we once had. Like when I was a medical student here in Boston, like in the late Pleistocene, it was probably before most of you were born, but the idea that someone with a serious mental illness would become hospitalized, would become homeless, or would end up in jail was actually pretty unthinkable. Like we had beds, we had a workforce, we had a safety net. This was in the 1970s, most of which is gone now. So sometimes people ask me, like, where could you get the best care? If you had a family member, where in the world would you go? And I sometimes say, believe it or not, maybe to 1975. Because it's not completely true. It wasn't great then, but at least there was a system. And we had some capacity in terms of these kinds of issues. The hospitals were not great, but people were not on the street, and they weren't incarcerated, generally. There's also, when people today, one thing that we deal with a lot is that people are just outside the system. So there's just not, more than half the people who should and could be in care and who would benefit are not in care for a bunch of reasons. It's probably not so much stigma. It's a lot of it is, and it's maybe not lack of access. People just don't like what we sell, or they just don't think they need it. So there are a bunch of things that fit in here, but we need to understand that lack of engagement. It's not a problem that we see so much in cancer, cardiovascular, any other part of medicine. And unlike other parts of medicine, the more you need care here, the less likely you're going to get it or even seek it. So this is really a different animal in trying to understand this engagement problem. When people do engage, what they get is not great. There's just a lack of quality. It's a system that's really built for episodic care, it's crisis care, it's reactive. It's not really what you'd want for anyone in your family. Highly, highly fragmented, very hard to navigate. And any of you who have looked for mental health care know exactly what I'm talking about. If you can find somebody, they're probably not covered by insurance. Here in Massachusetts, more than half of the providers don't accept insurance anyway, and very few of them actually have availability. This is a field in medicine that doesn't have really any accountability built into it, so we don't have the kind of measures like you would have for diabetes or hypertension and many other areas. And that's a problem, because without measuring outcomes, you don't improve the quality. And then finally, there's a problem with equity, which is probably not equity in the way you usually think about it, but what I'm going to tell you is that particularly people with serious mental illness in some ways are really, for the United States, they've become our untouchables, which is why they're incarcerated, it's why they're homeless, it's why they die early. And we'll look at some of that data. In fact, here's what I'd like to do, just quickly, because I want to make sure we can talk about some of this. I want to go through each of these and just give you one image to take home and to think about. And we'll just start with the lack of capacity. That's probably a good one. It's an image from the book. And it looks at this history of what we used to call deinstitutionalization. Now we call it transinstitutionalization, the way that in the 60s and 70s, as I mentioned, people were actually in hospitals. Those hospitals were, the beds disappeared. And we defunded state hospitals. And instead we funded criminal justice, or that's actually not the right word. I think criminal justice is like being a little too, it's a euphemism maybe. The carceral system, we funded the carceral system, and that's where people with mental illness on any given night, as you can see from these numbers, probably 10 times as many people with schizophrenia in a jail or prison than in a hospital bed, a public bed. That's unbelievable. That's certainly not true for diabetes. Wouldn't be true for almost any other medical problem. But that's what we've decided as a nation, that the way we want to handle this problem. I mentioned engagement as an issue, and here some data that we collected when I was at NIMH, just to kind of give you a sense of what that looks like. I said, 40% receive services. About 40% of those get what we would call minimally adequate, evidence-based care. Third get well, third get better, and third don't do so well. So I call this the 40-40-33 rule. And it was like one of the things that I mentioned, I did this tour, and I would talk to families, and they would say, this is just a hot mess. We're not getting any care here. And I would talk to providers, like I ended up finding some psychiatrists that I trained with in California, and they said, we're doing great stuff. Like the people we take care of, they really do get better. We have great things to offer. It's so much better today than it was 20 years ago. And I couldn't put those two things together because I was finding all these people who were homeless or incarcerated, and they were telling me that they were doing so much better. And it's because they're at the bottom of this waterfall. So they're seeing 0.4 times 0.4 times 0.33. They're seeing like 6% of the population that needs care, and they're doing okay, at least for 2/3 of them. They're doing pretty well. The problem is that you're never going to get a population impact with that. You have to move way, way up this cascade and start to get many more people. You've got to be at 80-80-33 or something like that if you really want to see the effects. And in fact, if instead of talking about adults, you're talking about kids, it's worse. It's like 20% are actually getting care. And for substance use disorder, at least for opiate use disorder, we know that about 10% are actually in medication-assisted treatment. So the numbers are really telling us that the problem is not so much stigma and access, it's really engagement. It's getting we have good things to offer, but people don't get them. And we have to solve that problem, and we will, but you have to hold on to hear about how we do that. Quality. This one, I struggle with the best way to show this, but just to summarize that what it's like in the world that we're in here, which is so different than any other part of medicine, but there's just such a fragmented system that when people leave the hospital, and we know this first 7 days is kind of like valley of death for a lot of patients, mostly they're not seen by anybody. More than half the time, they are not seen within 7 days after discharge, which is the critical time to get medications renewed, find your therapist, get into a recovery program. All of that doesn't happen. Most of the people who call themselves therapists have almost no training in any evidence-based treatment. There's pretty good evidence that the best treatment for depression would be medication and therapy, but very few people get both. You either get one or the other. And it's, we'll say more about this, but there's great stuff in the world of psychosocial rehabilitation. Very, very few patients with serious mental illness ever see that. So the bottom line here, and I can't stress this enough, is that we have stuff that works. And yet the real tragedy is that we're not getting it to the people who need it in the way that they can use it. All right, real quick, and I just want to finish this up. Accountability has to do with measurement. We know that, in this case, just a study done on the treatment of people with depression, adults, shows that if you simply measure outcomes, the outcomes are much, much better than if you don't. This was done in a double-blind fashion. So the green lines represents a group of people for whom there were measures of depression every week, and the orange line, the outcomes were measured, but they were not shared. And so you can see it really does matter to be able to do what's called measurement-based care, but unfortunately, less than 20% of practitioners ever really do that. So that's, again, sort of unthinkable. Now, the last thing I wanted to talk about was equity. And I told you that this is not in the sense that we usually talk about equity, but it's something I really do want you to think about. I got into this idea that for the book, that maybe one way to understand this as a social justice concern was to think about people with serious mental illnesses being a kind of racial ethnic minority. And if we just thought about that for a moment, where would they rank with respect to other racial ethnic minorities that we're very, very focused on in terms of equity? And you can see it ain't great that in terms of life expectancy, employment, the relative risk of use of force by police or rates of incarceration, they're about as bad off as anybody in the country. And of course, if you're talking about a person with serious mental illness who happens to be Black or Hispanic, it's even worse, right? So you get double jeopardy if you're in both of those lines. But I think it's important to look at this because in the interest of sort of all the DEI programs that we talk so much about in medical schools in particular, this never comes up, even in departments of psychiatry. I'm in the Stanford Department of Psychiatry, and there's this huge focus on equity and inclusion, and yet no one's ever bothered to mention that people with serious mental illness who, on our watch, all this has happened, are so much worse off than any of the minority groups that we're trying to be equal and inclusive with. So I just think we have to reframe this and begin to understand the depth of this problem. And again, this one's solvable, and we'll get there. Let's talk about solutions, actually, because I think this is the moment in which the sun comes out and we can begin to feel a little bit better about what we're facing here. I started by saying this is like the best of times and the worst of times, and what I've just told you, it looks like the worst of times is actually getting worse since January, but the best of times are, in fact, on us in this field because there's so much we can do now that we couldn't do before. Well, as I was working on the book, there were things that I just didn't understand, and part of what is wonderful about writing a book like this is it's both clarifying and edifying at the same time. It takes you places you didn't know you were going to go. The three things that I learned that really surprised me and that are just incredibly hopeful is that some of the most effective things here are the least expensive, that you can use peers and coaches and come up with better outcomes than you might with people who have an MD, PhD, and many other degrees after their names, that some of the most effective interventions are things that may not be expensive, high-tech medical interventions requiring, a 7 Tesla fMRI scanner, that clubhouses and housing interventions and peer support groups like AA, they really work and are incredibly effective. They're not part of the health system. And that's interesting to me, but they are effective in opportunities that we need to keep our focus on. And some of the people who I met who are the most disabled by their illnesses are, once they get into treatment, can do incredibly well and actually become part of the solution. And that's, to me, just so inspiring and so hopeful, and we tend to forget that. It's in the book I talk about individuals who everybody had given up on, and yet when they get well, they are able to do so much for other people, and that it's just so important for us to remember. Just because we're seeing somebody at the worst moment of their life is not necessarily the way they need to be for much longer, and that depends maybe more on us than on them. So my argument here is that this isn't about spending a lot more money. It's about really thinking about what works and paying for the things that work. So that was one of the sort of epiphanies that said, wow, we can do this. Like, this is not rocket science. It's actually the opposite of rocket science. This is stuff that we should be able to do. The other thing that's happened in the last couple of years especially is this explosion of technologies that really will matter. I'm not going to spend a lot of time now on this, but maybe we can talk about it later. But the fact that AI is really will transform healthcare, but it'll transform mental health care more than any other area. AI is very good at communication, both receiving and generating language. And that's so much of what we do in the mental health world. And whether it's just for documentation, which is a thing we can do right now, whether it's to help with diagnosis or help for treatment, this is the technology that really is going to change the way we deliver care. It's not to replace people, but it's to empower people in ways that give them all access to information, keep them from having to spend so much time in documentation, especially in the world we're in that, everything has to be a fee-for-service, minute-by-minute kind of documentation. It gets rid of all that stuff and allows people to really do what they uniquely can do. So I love this idea that we're coming to kind of this precision mental health moment because of this technology that gives us the right treatment for the right person at the right time. So with those things in mind, I want to just very quickly go back to our problem statements and say that there are actually solutions we can put in place for each one of them, and we need to think about how to do that. And I hope to give you some examples of how that plays out. So on capacity, that's not a hard one. You just have to say this is important, and you need to start investing in it the way we used to do it, and the way it's done in Europe and many other countries. But in this country, not so much. Engagement, and actually I would say quality and accountability, all are going to be transformed by our ability to meet people where they are, using technology in new ways, training up a workforce, which we can do really well, and then creating ways of measurement that build in the accountability and even the equity piece we can begin to address with these recovery services. So again, I'll just unpack each of these quickly so you can get an idea what I mean. Investment, we've got both private and now public investment. Massachusetts has been pretty generous. Many of you have been involved in this roadmap that's generating lots of ideas and some also really great services already. There's been a workforce initiative from the state. MGB has pledged $50 million. Blue Cross Blue Shield has leaned in on behavioral health here. So there's a lot going on the public side. Certainly the federal government over the last 5 years has just done an amazing, really unprecedented number of initiatives, particularly for what are called the CCBHCs. We don't have them in Massachusetts, but in probably now 24 states. This is a $10 billion program that is for community mental health centers. We do have community mental health centers in Massachusetts, so we may not need the federal version of this, but these are really exciting and a chance to sort of provide the kind of comprehensive, no wrong door, whole person care that we haven't seen for a long time. We've seen increases, when I was in government, CMS, Medicaid, Medicare, there was no one at home all the years I was in government on behavioral health. We had one person who was sort of an expert, but I could never get him. And now there's an army of people, or there was, I don't know if they're still there, probably not, but up until a couple of months ago, this was a huge, huge new effort for both Medicaid and Medicare. Something that it was not only that there was a lot of investment, but there's a lot of expertise and innovation and creativity. So it's really exciting to see all of that. If we think about engagement, quality, accountability, a lot of that can be handled by just putting the right kinds of tools in place. And we know that, like for engagement, we've now got remote teletherapy that's available with evidence-based treatments so that you can get the same care in Botswana as Boston from often the same individual. And it's done in a way that is convenient, meets you where you are, and can be very high quality. It's wonderful. Quality itself is not ensured by having access, but it is ensured by having those things that were missing when I said we had a very reactive, very fragmented system. You can now begin to coordinate, you can begin to capture data, you can begin to actually build in the sorts of measures to know that you're doing better or not. And accountability is now possible because we're developing objective ways of knowing whether somebody's better or not. This is called digital phenotyping. It's not a great name, but it's a way of using objective data. So instead of asking someone, how are you sleeping, you make sure they have a Fitbit or some wearable or an Oura ring that actually tracks their sleep, so you actually would know. Just like you don't ask a diabetic patient, how's your blood sugar? You measure the blood sugar or the hemoglobin A1C so you know. The beauty of all this is the way in which it can all fit together to create this kind of learning feedback engine, which we now have for diabetes and we could have for mental illness. It's not fully built, but it will be. And we have all the tools to do that. And we can begin to use tech in some really interesting ways, both not only to reduce the fragmentation, but to make sure that there's less delay in the way people get care and to actually help the training of people so they don't burn out as much and you let them do the thing that they most want to do. Equity. I told you that I wanted to talk about this recovery-based care thing. And what I really mean by that was actually what Ethan introduced, and it was something that I learned when I was on Skid Row. That's where these pictures were taken in Los Angeles. And I was asking a street psychiatrist there about what do you do here? What's really helpful? And he talked about recovery, which I didn't fully understand. When I asked him what it was, he said it's so simple. As Ethan said, it's people, place, and purpose. It's giving people social support. It's making sure they're in an environment where they can be safe and they can get reasonable nutrition and they don't have to be stressed like they would be sleeping on the street, and making sure they have something to wake up for every day, some purpose, which is the thing we never talk about in healthcare. So people, place, and purpose became really what I built the book around. And I thought about that because, again, we know how to do this. We have 60 or 70 years of experience of those services that are available, broadly called psychosocial rehabilitation, that do exactly this. And those of you who work at Ivy Street know this is your bread and butter. This is what you do. What's amazing to me is that as effective as these are, and we have enormous amounts of science to support ACT teams and supportive housing and supportive employment, we know all this stuff really works. It really helps people to recover, but we don't pay for it. And in this country, where healthcare is largely a business, what you do is what you get paid for. We pay for the top part, the medication, primary care, cognitive remediation sometimes, but much of the rest of this, depending on the state and depending on a bunch of other things in the budget, they're really left up to philanthropy. Now, we don't do that for diabetes, we don't do it for dialysis, we don't do it for lots of other chronic issues. But here we've decided, you know what, we'll pay for the medical part, but not for all that other psychosocial stuff. Even though that's the stuff that doesn't cost very much, and it's actually far more effective. And I wanted to give you just a few examples of that. I'm on the board of something called Fountain House, which is a clubhouse in New York City. It's been around longer than I have. It's like 75 years old. And it was the original iconic clubhouse. It was founded by people who came out of a state hospital and started supporting each other and their was called WANA, We Are Not Alone. You're always with, I have your back kind of thing. It was a social support group. But over time, it grew into a real, what's called an intentional community, people coming together to support each other. So it was founded by members, for members, and it's literally the 3 Ps in action. It's all about social support. It's all about having a place from 8 a.m. till 8 p.m. every day where you can get meals, where you have something to do, where you're surrounded by people who care about you, and you can get job training and a lot of other things. I mean, this is all very familiar for people in this audience, but I'll tell you, when I talk to medical audiences, they look at me like, what? Really? That exists? There are about 300 of these clubhouses around the country. Fountain House is probably, I like to think of it as kind of the best example of how to do this. And we're now taking Fountain House and sort of franchising it. So we've started a Fountain House in Los Angeles, we've got one in Harlem, one in the Bronx. We're actually changing the model a little bit in this last 18 months to include housing as part of it. So what we're doing in Harlem and in the Bronx is we're getting a building, 5-story building. The top 4 floors are residential units, and then the first floor is the clubhouse. And I think that's the model that we want to go to increasingly as we build out this national structure that we call Fountain House United. If you haven't seen it, there's a wonderful program in Phoenix that I was involved with years ago, and it's now really taken off, called First Place. Some of you may know it. It's a residential setting for transitional age youth on the autism spectrum, and in really the full spectrum. So there are kids who are living there who are pretty severely disabled. The deal is they all have to work every day, and then they come back, kind of like the flip side of the clubhouse. So they're out all day in jobs, and then they're back where they get lots of support in the evenings. They do their meals together. It's this beautiful, like Fountain House. It's like a beautiful, beautiful architectural dream. And the services are spectacular, and it's set up in a way that makes it really easy, with the idea that kids are going to stay there for years, maybe decades, as necessary. It's not big enough for more than, I think, 60 or 70 kids, but and they're not kids after a while. These are people who, some of whom cycle through, but many of them are staying long term. It's a really great example of, again, an intentional community that's done, particularly for this population. There's some things in Massachusetts, many of you know about these. Team Up is I think a really interesting, maybe a national model for how to do collaborative care, like integrated healthcare for kids, so pediatricians and behavioral health support. Mass Health has developed this roadmap. It's not completely implemented yet, still in the works, but a lot of what they have done around the helpline is really impressive. I've looked at a lot of these across the country. I think this one may be one of the very, very best, with kind of immediate access to care, both high acuity, low acuity, anytime, 24/7, across the state. It's really pretty spectacular. And Massachusetts, of course, is really famous for this Child Psychiatry Access Project, which is it was the first in the country to have telepsychiatry. Many of you know about that. For anybody looking for assistance, really with just a simple phone call, you can have access to a child psychiatrist if you're a pediatrician. So let's finish up, because I promised you that we'd have some conversation. Our 3 buckets, I want to, without taking the time, just tell you that for all 3 of them, we have good stuff to do. We know what to do. It's really now leadership, commitment, investment, and that's what I'm so concerned about. So let me stop with this rather dire slide and let you know, let's think about where we're at in this moment with a budget that calls for $880 billion to be taken out of Medicaid and Medicare over the next 10 years. For those of you who think, is that a lot of money? The Medicaid budget itself is about $880 billion. So maybe it's just chance that was the same number that the Republicans put into this budget. But what will happen to Medicaid, which is the biggest payer of mental health care, is really, really unclear right now. And each day there's a new conversation about what this looks like. I'm not going to go through all of the different pieces of this, but we haven't faced anything like this in my career. This is, and I've been doing this for 50 years. This is huge, and it's very, very concerning, because even in Massachusetts, a 10% cut to Medicaid will have dire consequences for the kids that we serve. There's just no question. This is how most of our folks will get health care. And if you think, well, they have private insurance, most private insurance companies today contract with Medicaid and Medicare. And so if they aren't getting the dollars there, it's going to be really hard for them to give the services without huge increases in premiums. At the same time, services are being cut. We're cutting the R&D lines. And I mentioned before about the Department of Education potentially being shuttered, but my old agency, the NIH, is being thoroughly gutted, which is to me remarkable, because this is sort of our pipeline. This is where new treatments, new ideas, innovation comes from in this country, is what I think of as really the jewel in the federal government, the jewel in the crown. And it's very clear that much of the leadership is either gone or heading for the exits. And so this is an agency that will take a very, very long time to recover. It's true for SAMHSA, FDA, CDC. You can go down the list. So I don't know exactly. It's a lot. So much of this is new, how we respond or what we do. But I do know that this is going to have enormous impact on the people that we serve and on us. And we're going to have to think what this requires of all of us to be able to continue to provide the care like we do at Ivy Street in an environment where the federal government is basically MIA, and the state can't fill the gap. So on that sort of really dire note, I'll end by saying I remain intensely hopeful, cautiously optimistic, because I do think there are ways that we can deliver good care that aren't necessarily super expensive. The point I've been trying to make all along is that we don't need to spend a lot more money. We need to just do this in a smart way. But this isn't going to help. This is not the right way to do it. And so slashing budgets, destroying the federal government and the agencies that are there to help build our safety net is not the answer right now. So on that note, let me stop. I really want to invite all of us to sort of be part of this conversation. We're going to have to deal with this collectively. We're going to have to think through what this looks like going forward and come up with a plan that makes sure that the people we serve aren't hurt by all these changes. Thank you so much.
Hi, everyone. At this point, we now invite people to ask Dr. Insel questions. Who'd like to kick it off?
Thank you so much. It was great. Jean McGuire, one of the board members. It was wonderful. There's so many interventions that we have at Ivy Street and in our transition and adult programs that are those lower cost but effective interventions that it's really hard to get reimbursement for. So I wonder if you might talk about, so how do we go from, well, the evidence is that it works, but the payment's hard to find?
Yeah, so that's, Jean, that's the fourth P, right, is payment. And there are a couple things to say. One is there is, in spite of all these dire notes about the cuts, there's huge amounts of investment in innovation here. So that's still very robust and hopeful. And one of the ways in which those investments are playing out is people are trying to prove out a different payment model, which moves away from the fee-for-service model towards more of like what's usually called a value-based model. I mentioned those CCBHCs, the Certified Community Behavioral Health Centers, that the Congress put $10 billion into that in 2022. And that program has what's called prospective payment. So if you're running a community mental health center in a state that has a CCBHC, you get a big pot of money to deliver whatever care you want to deliver. And that's theoretically could really open up the gates to doing the kinds of things we're talking about here, like a clubhouse, which isn't that expensive, but isn't usually paid for with healthcare dollars. Well, now you could pay for it. And you could prioritize those things like psychosocial rehab that are probably more likely to deliver recovery outcomes without having to worry about, well, there's no code for this, so that, I can't bill for it. So I think moving away from fee-for-service is one way to get that fourth P done. The other piece is just to demonstrate the evidence that, and where this comes out, I have a company called Vana Health that's doing exactly this for people with serious mental illness. And the case that we're making is that by investing in psychosocial rehabilitation, you are spending a little bit more money on the behavioral health side. But if you talk to the big payers, they're not really spending very much there anyway. So they don't really care that much. Where they do care is on the other side of their budget, which is cardiovascular, pulmonary, emergency room services, all of that. If you can save on that line, that's worth a lot. And we know that untreated serious mental illness and untreated substance use disorder drives up those numbers enormously, 6-fold higher medical costs. So the idea is providing behavioral health care brings total cost of care way down. Now, that only works if you have an integrated system. If you carved out mental health, it doesn't work very well. And so beyond just moving to a value-based payment system, integrating care, getting past the carve-out is going to be really important to answer your question, to finally get there. But I'm kind of hopeful that we can do that. And I think it's just these are, accounting issues. These are really actuarial concerns that are, at the end of the day, going to be argued by the numbers. And I think you can show that having a clubhouse and providing ACT teams and community health workers really does save a lot of money on the total cost of care.
Hi, I'm Karen Quigley, another one of the board members. So for most human service organizations, at the forefront of our mind right now is workforce and workforce issues. Could you talk a little bit about the workforce in the mental health world, what it is now, how it has to change, and what some of the challenges are?
Yeah, thanks for that, Karen. I do think that's become a huge concern, and it's going to be worse when the budgets are slashed because you won't be able to pay people. But even now, what we're paying frontline workers is insulting. And I'll just tell you the California experience, which I know firsthand, where we've lost a lot of our care managers, frontline workers in the county system. We've lost them to Target and to they've gone to work for Amazon because they get paid better. And it's really not, what we're asking them to do is hard. They went into it very mission-driven, usually, not for the money. But they leave partly for the money, but partly because they find they're spending, and this is not an exaggeration, they're spending 50% of their time documenting what they're doing the other 50% of their time. Because again, we have a fee for service. You have to account for every 3 minutes of your time. It's just soul crushing. It's awful. It's not what they really signed up for. I think that's a problem that's solvable by AI with a push of a button. Like today, we use digital scribes. So we have like a company that I have here in Boston called Advocate MH. The idea is we have a care manager who interviews you over the phone. Everything that you say and she says are captured by a digital scribe, rendered to text, analyzed in 18 different ways. They automatically fills out all the rating forms, all the reimbursement forms, everything that these care managers are spending all their time on is automated with a push of a button. And that's not research. That's done now by thousands and thousands of providers. But it's been very slow to get that into the mental health workforce. And I don't know why. I don't know what's keeping them from understanding that we're in a different era and we don't have to spend time in documentation anymore, that we know how to, even prior authorization is being automated. I mean, all that stuff is really, AI is going to solve a lot of those issues and really help the workforce. As I say in California, we can double our workforce with a digital scribe, literally, and without spending any money at all, with the same people. And I think we'll retain the people who are currently leaving, so we won't have the turnover. But it's just been hard to get that adopted. And I'm not. I think it's a case in which people are so busy in the moment trying to keep up that it's hard for them to see the solution that might be right in front of them. The other way that technology will really help us is in training the workforce and giving people the opportunity to practice on lots of AI patients that we can generate. And there are already many, many, many companies that are doing this and providing training not only for community health workers, but even for peers to be able to help each other. So, and that's the last thing I'd say about this, is that one of the things I didn't expect when I was working on the book, but I came to learn through yet another company that I worked in called Humanest, was the way in which you could empower people to help each other. We have this belief coming out of medicine that it's really, you need an expert to do all of this stuff. And it's very disempowering. Basically, it's a very hierarchical, paternalistic system that says, I'm hurting and you have the solution and I need to go to you to get that. I don't know that that's necessarily useful in the mental health space. I think increasingly we can give people the tools to help each other. We can build community that way. And what we did at Humanest, mostly working with university students, was we simply gave them the opportunity, we empowered them to be part of the solution. They'd come hurting, and pretty soon they were healing. And when we looked at that and tried to understand, like, what was that all about, what we heard over and over again was, what was most helpful wasn't getting help, but being given the opportunity to give help. And being taught how to do that was just transformative for a lot of kids. And so I think we have to change the way we think about the workforce a little bit. It's not the answer to all questions, but between AI sort of changing the training and then giving, using peers and increasingly empowering people to help each other, there's a lot we can do.
Thank you so much. So I wanted just to clarify one of the things that you were saying in one of your presentations when you said one person either has the medication with the psychiatrist and one person has the therapy. I was told by multiple people, really, is that isn't it like a combination of medicine and therapy to have the person heal and recover?
I'm sorry, I missed the last part. Isn't the combination?
Isn't it a combination of medicine and therapy for the person to recover?
Yeah, thanks. So that's I'm sorry I wasn't clear. That was the point I was trying to make. The way we have our current system set up, people usually end up seeing a primary care physician or a psychiatrist to get medication. They see a therapist, usually a social worker or a psychologist, lots of other jobs in there too, to get psychotherapy. The science is pretty clear. All the clinical trials that have been done, as you said, the combination for depression and anxiety are more effective than either one of those two alone. And in many countries, that's the way this is done. But in the United States, really for workforce reasons, we've separated out those two, which is never ideal. Sometimes it's sufficient, but often not. So the opportunity to bring those together, I think, is one of the things that we can do fairly quickly. Actually, I mentioned Advocate MH, the new company here in Boston. And part of what we do for our advocates is they ensure that people get all of the potential kinds of treatment that can help. So that could be medication, it could be therapy, it could be being part of a peer support group, or going to AA, or being part of a church group. There are a whole bunch of things out there. We have this idea, and some of this comes from the sort of infectious disease model that we tend to use too much in mental health, that it's a bug and it needs a drug. And if we just find the right drug for the right bug, our problem is over. That just doesn't work here. And we're going to have to understand that these are more complicated issues that require lots of different interventions. And we need to figure out a way to coordinate those and make sure people have access. Thank you. Yeah.
It's me. Oh boy. Hello, my name's Aileen. I'm with Skills for Life, the community-based OT program that Brooke was referencing. And something that convicted me about your book was the discussion about outcome measures and accountability for mental health providers. So when we're talking about social-based supports, peers, coaches, clubhouses, AA, in combination with the accountability of quantifiable outcome measures, for you in an ideal non-payment driven system, what would some of those outcome measures be to track the success of more community and social-based supports?
Yeah, thanks, Aileen. That's exactly the conversation we had at Advocate MH this morning, was like, could we come up with that perfect set of assessments? In the world of physical rehab, we tend to ask people about their pain, and then we look at function. Can they walk? How far can they walk? How much can they move the joint? All that sort of stuff. Can they begin to lift? That's what we need to do here, right? So the outcomes that most people do in the healthcare system would be a PHQ-9 for depression and a GAD-7 for anxiety. That's not telling you really what most patients and families want to know. Are you back at work? Are you back at school? Are you able to sleep? Are you able to function? So getting those kinds, so I think where we are now is coming up, you do have to measure symptoms. You want to measure functional measures like, what are you doing every day? And then I think you want to look at recovery measures. And what we call recovery measures are asking people to set goals for themselves at the outset. Like, what would success look like for you at 6 weeks and at 3 months and at 6 months? And then checking back to see, have you gotten there? And maybe, those aren't the same for everybody. For one person, it might be, being able to travel. And another person, it might be living independently. I don't know. I mean, you have to, I think the process of setting those goals is actually a key piece of the therapy. And yet, again, in healthcare, we don't really do that. Oddly, we do it on the physical side, but we don't do it here, and we certainly could. I think there was a question over here, too.
Hi, I'm Anastasia. I've been a member at MAB here for many years. I also have an immediate relative who goes to Fountain House, so thank you for that. I would love to sit in front of legislators and donors and get billions of dollars and change the world, like I joke with my coworkers all the time. But I am a member of the MAB team, and while I have change here, that is one piece of it that often feels overwhelming, like it does, I'm sure, with all my other coworkers. So if you could speak to the MAB staff, the Ivy Street staff, our future employees, what is something that we can do on a small scale that will help alleviate some of the immense pressure that we feel, especially in 2025?
Yeah, this is really the question that I want all of us to talk about. I think, and I'd be really interested in how this moment is playing out for your students, what they're hearing, what they're feeling. I can tell you, our members at Fountain House, they feel this is very personal to them. They feel targeted. They literally feel targeted. They feel like they don't know that it's safe for them to go out, which is amazing, really. So I think it's important to know that. And what I was going to say is to convey hope, But actually, I'm not sure that that's the right message yet. I think what you want to convey is concern and to say, we're all in this together, right? I mean, we're all feeling something here that we need to understand, and we're going to need to stand together. I keep talking about the experience of writing the book and kind of what I came around to, and there's a piece at the end of the book, which again, it's so interesting how this happens, because as you write, it sort of draws you along and it gets you thinking about things you hadn't thought about before. And I came to this idea by the end that really what we need is community. That's kind of what's missing, leadership and community. And how paradoxical it would be if we build community by focusing on the people who need it the most and have it the least. And that they become actually the source for all of us to recover. They become the kind of the healing crystal for all of us because they need it. And we can begin to do that. So I would say for this community, for the school, and for the broader community, I just think this is the moment to sort of share and talk about it and try to get really clear about what it means. I mean, what we've done at Fountain House is we've all come together around this to say, this is scary, and we don't actually know, like, are we safe, and what we can do, but we at least have each other, and we'll make this a safe haven. And that's something for our members. I can tell you that's mattered to them.
Hi, I'm Sheila Gouch. I'm the principal and clinical director at Dearborn Academy, which is another 766 school. So thank you to Ivy Street for bringing Dr. Insel here. My question is really around education right now and the impact of the mental health crisis on us as educators who are kind of on, certainly those of us in 766 schools who have I know we have at Dearborn probably the largest number of families who have failed mental health providers who are walking away from our students. And we are really left, I kind of call it the last man standing is education, right? We're the ones that are legally mandated to support these students. So I'm just wondering kind of what your thought is on shoring up the educational kind of mental health force as well, or kind of how we support educators. I do a lot of trainings for districts as well, and I just hear the need and the acuity is so great, and just kind of wondering how we can support education as well.
Oh, gosh, I don't, again, I think it would have been a much different conversation 3 months ago. I'm just not sure. I don't know that if we got the Department of Education, if we got SAMHSA, that there's going to be the kind of supports that we're even used to. So we're going to have to think about philanthropy. We're going to have to think about state money. We're going to have to think about other ways. And maybe this is, again, where we have to hope that technology gets us some efficiencies. But there's no simple answer here. And I wish I could give you something. I don't think I can. Kevin.
So, hi, I'm Kevin McGrath, Chief Strategy Officer at Ivy Street. I want to talk a little bit more about what do we do when they got this funding, and who do we look to, let's say that the funding doesn't completely go away. We're still talking about how do we get to the point of expanding and implementing the things that we know that work that we're not able to do on a broad scale already. Either way, whether they got it or we still have it, we need more money, right, in order to do these things. So who are we looking to? Who do we have to get in front of? I know Anastasia said, we can dream about getting in front of those people, but who are they and how do we do it?
Some of them might be here in this room. You never know.
Yeah. Yeah, so Kevin, I think you're raising the need for people to step up, right? So this is the moment when philanthropy will really matter. I don't know how long that will be true, but at least for the next couple of years, we're going to need new sources. We're going through this at Fountain House, so we're going back to former donors, but we're trying to generate new donors. And I have to say, there's a lot of interest in the private sector for increasing philanthropy. I think people see that there's a need, and you're seeing this with Bloomberg and Gates for WHO and for USAID. They're coming in behind those agencies to try to shore up the most acute needs. But here, what I would say is, I think you've got to have a good story to tell. Mike is great for that. Like, he can do this. So you need someone like Mike who is, maybe out on the stump more than being at home, because it's going to require getting some generous people who care about what you're doing and being able to tell the story of what you would do with the money they give you. Maybe that's the place to, is there one more? Okay, let's finish up.
It's
Thank
more
you.
of a statement than a question because
Yes.
workforce asked my question. Oh, sorry. My name is Chris Peralta. I'm an occupational therapist with MABV. 11 years last Friday. Thank you. Anyhow, I know I made it. Thank you. All I wanted to say was I like the idea of Fountain House. I've heard about it. But what I see here at MAB is the fact that in MABV anyway, we have an awful lot of people. I work with people 6 years old to 96. We have an awful lot of people with macular degeneration. And part and parcel of macular degeneration is depression. It's not the only one. Glaucoma, RP, I could go on. But the issue is we've got PEP groups. It's like people empowering people. We've got groups where they leave their house. They get out and they talk to other people. And even if all they do is sit there, and I've seen people just sit there, they are out of the house. They're listening to other people's problems and they're like, wow, my world's not so bad. Or she's got it worse than I do. And then they start to come out of their shell and they talk to each other and they make each other better by just being there. Now, sometimes, especially after COVID, they can't get out. But they're on the phone. They're on their iPads. They're on whatever tablet they've got, and they're in a Zoom meeting talking to other people and making their lives better. And I've seen that with MABV, and I think it's wonderful. So it's working.
Oh, thank you. That is a great place to stop. Thank you so much.
Thank you so much, Dr. Insel.
Thank
That was
you.
wonderful. Hi, everyone. My name's Laura Alpert. I'm the Chief Advancement Officer here at MAB Community Services, and I want to thank Kevin McGrath for doing my job. And you too, Anastasia. I see you. So thank you, Dr. Insel. And thank you, everyone here at WBUR CitySpace and our Zoom guests. What a deep and thoughtful discussion, which I'm sure will continue tomorrow when Dr. Insel visits Ivy Street. Thanks again to the WBUR CitySpace team. We also thank Catering on the Charles, Wegmans, and At Your Service for the great food and beverages. I'm excited to share an opportunity for everyone here tonight at CitySpace who is affiliated with Boston University. Our talented photographer over there in the corner, Darlene DeVita, would love to get a group photo with all of you. And yes, Darlene, we do have a stepladder for you, so you'll be able to command and control from there. So all BU students, alumni, current and former faculty and staff, and Delta Gammas, please join Darlene in the lobby now. That includes you, Dr. Insel, Bev Brown, if she is here, Brooke Howard, and others. Please join the BU group for the photo. And the rest of us at CitySpace will give you a bit of a head start. And we'll email you the best photo after the event, we promise. We've got two more great opportunities here tonight at CitySpace. Frugal Bookstore is selling Dr. Insel's book, Healing, Our Path from Mental Illness to Mental Health in the lobby. And whether you brought your own copy like I did or buy his book here tonight, Dr. Insel will happily sign it. And finally, we invite our in-person guests to join us for coffee, tea, water, and dessert in the lobby. And to all our friends who joined us on Zoom, thank you so much and have a great night.